please welcome back to the stage the founder of the HillVets Foundation, Mr. Justin Brown.
All right. Good afternoon. How's everyone hanging in there? Yeah? Woo! Reception soon. Secretary Hagel, everybody get excited. It's been an incredible day. I've been super impressed with everything I've seen from both our panelists as well as our lead cohort and the work you all have done in making today a reality, covering so many important issues that really touch our military-connected landscape, you know, from veterans' first day of enlistment and recruitment. We've discussed so many different things, and I think our panel right now really illustrates that idea, which is, you know, from the day a military service member, from the day a civilian, a young civilian, man or woman, becomes part of the United States military service, a service member, through, you know, really end of life, right? When we're talking about VA and VA benefits, in some ways kind of beyond life when we're talking about VA benefits and services, right? Some of those benefits continue on to military spouses and children. I know when I worked for the VA, Secretary Shinseki used to talk about how we were still serving the Civil War generation at that time. I don't know if that's still true, but this was true, you know, 10 years ago, that there were dependents from the Civil War era that we were still serving at VA. So I couldn't be more excited to have a panel of folks from a fine organization that is really taking on one of the toughest challenges facing our military-connected community, and that is the electronic healthcare record. So I'm excited to welcome to the stage, first, Patrick D. Sargent, Senior Vice President and General Manager, Cerner Government Services. He is a retired U.S. Army Major General. He joined Cerner as a Senior Vice President and General Manager of Cerner Government Services, where he leads all federal client account management. He has an incredibly impressive background, but probably most impressive is that he's an honorary HillVet, having worked as a congressional fellow on the staff of U.S. Senator Richard Durbin, working on his VA and DoD portfolios. All kidding aside, his bio is way too long to list here, but you're an incredibly impressive man, sir, and we're delighted to have you here with us today. Also joining us is Daniel Thode. Thode, I know I was going to mess that up. It's not like I haven't met you before. Managing Director of Defense and Military Health, Cerner Government Services, where he has focused on all aspects of business development, delivery, and client relationships for Cerner's military health business. So really on the DoD side, where he's focused on DoD's health record, MHS Genesis, and the U.S. Coast Guard health record modernization. And last, but certainly not least, is Avi Vaswani, Vice President of Cerner Government Services. And he hails from Richmond, Virginia. And if you've been fortunate enough to join them in any of their discussions with the VSO community, he's our technical ace here. So when you've got the tough questions, he knows his stuff, and we're grateful to have you here with us today. First, I think, go after, General, maybe you can kick us off. Tell us a little bit about yourself.
Yeah, well, I appreciate that. And first, I want to say thank you and HillVets for allowing us the opportunity to partner with HillVets. As mentioned, I'm a former congressional fellow, so I understand the importance of having a fundamental understanding of the legislative process, particularly when you think about some of the challenges that are facing our military and our veterans. And so I heard the discussion about service. For me, service is action in motion. It's not a title. It's not a position. It's all about performing and giving back to those that are less fortunate than yourself. In fact, I pinch myself every day. Having been raised in Panama City, Florida, single parent, all the welfare and everything else, the government subsidies, go out to Florida State University with $20 in my pocket, my grandmother and mother crying at the Greyhound bus station. And then fast forward to 2022. And you're saying, I'm testifying on Capitol Hill today in behalf of the 18 million beneficiaries for the VA. Who would have thunk it? I say all that because it was the Army that gave me those opportunities. And so I would tell you that just like the folks in this room, I believe having experienced military service, we come about with significant skills, knowledge, and expertise that I think translates exceedingly well to the commercial sector. That said, we all know that it's about networking, but more importantly, I think it's about joining organizations that kind of match your calling. So for me, I learned very on as a dust-off pilot in flying in OF in Desert Storm and then flying in Iraq that, that calling allows us to be able to enter that space, that boundary zone between life and death, and having that ability to change that situation. And so for me, it's the same thing with regards to wellness and health. Whether you believe it or not, I see a lot of young folks in the room, you're going to get older and you're going to have some medical conditions, whether you like it or not. You need to understand that your health is your wealth. It's your future earning potential. So I would just say to you that we need to take a vested interest in those systems that the military or the veterans community are putting in place to protect our interests. I remember way too long about the USAA calls I would get when I was a lieutenant. I'm just, oh, that doesn't matter. And before you know it, it does matter when you get to that station in your life. So I'll stop there and just say, look, I'm proud to be here with you guys and look forward to interacting with you as we move forward.
What did you fly, General?
UH-60 Blackhawks, baby, dust off. Strength for the warrior, hope for the wounded, and comfort for the dying.
All right. I mostly worked on 46s, 53s.
Okay.
All the Navy aircraft primarily.
I won't hold it against you.
Yeah, that's all right. That's all right. Daniel, tell us a little bit about yourself. Kansas City, born and raised.
Kansas City, born and raised.
How do you end up running such a huge portfolio focused on the defense?
It's interesting. So my background is the opposite of General Sargent's. So I spent a lot of time in the commercial health sector, involving commercial health systems, big academic institutions, big for-profit institutions. And in 2015, when the military health system said they wanted to go with a commercial product, I thought I knew healthcare really well and complex health systems. So I said, hey, I'll sign up. I did not know complex health systems. I did not know the size and scale of what we were signing up for.
So it was a bit of faking it till you make it.
It was a lot of learning. It was a lot of learning from people like General Sargent and people who, like you all here, who have the experience with the military health system. When you bring a commercial system into most of the people like myself don't necessarily have military experience, don't have experience with the MHS or the VA. So it was a much larger learning curve for me going from commercial sector to public sector than it was for General Sargent to go the opposite way. And so I would say for those interested in the healthcare arena, coming with experience from a military health system or the Veterans Affairs, have a leg up in this space.
Awesome.
So that's how I found my way here 7 years ago and haven't looked back.
Yeah. Avi, how about yourself? How did you initially get involved in the space that you are now as being legitimately one of the lead guys working on one of the biggest contracts, projects ever in VA's history?
Yeah, my history follows a similar path, I think, in some ways. And, I started early in my career serving the VA mission back in 2011 with the program we're working on now. It was actually called the Integrated Electronic Health Record. It was VA and DoD's first attempt at doing what we're doing today. So this is, my career coming full circle. Ever since, I didn't have the honor to serve our country like many of you have, but what I do have the honor now is serving those who have served, and I haven't looked back. I've been with the VA, supporting the VA in many of its programs, and some of its largest programs, community care, improving access to care for veterans, and now with the Electronic Health Record Modernization Program. So if it's big, if it's complex, and if it's to the benefit of those who have served, that's where I want to be. And so I'm honored to be part of Oracle Cerner now, honored to be working under General Sargent, and honored to be in front of you guys today.
Awesome. Thank you, Avi. Hey, it's good to get to know you all a little bit better and your backgrounds. For me, in terms of, help us articulate why this project matters. Why are we even doing this in the first place? I remember getting out of the Navy, being told In fact, I heard the general talking about how he had his medical record on a floppy disk, and I thought that was a technology breakthrough, because I was making, I was told 4 paper copies, so I just had like copies and copies of and like, I didn't really even have any medical issues to speak of, but I was told, make sure you get your service record, your medical records and all of these things, because you're going to need them and they might get lost and you'll never find them again. So, here I am at the Xerox, in the month or so before I'm officially separating from the Navy, making all these copies, and I got this big bundle of, 8.5 by 11 white paper, just copy.
Right.
So why does it matter? Why are we spending, as a country, so much money on this problem?
So I think it's a recognition of the fact that we need a system that seamlessly transitioned from active duty to veteran status, that's truly interoperable. When you look at the current system in the VA, it's one system. If you go to one VA, you've been to one VA. It's been customized to the degree that it doesn't transfer over to other facilities. When you think about interoperability and trying to set the clinician up for success to make sure they understand your allergies, your AC1 diabetic or HEDIS scores, they need to see that to make sure they're not prescribing the wrong medication or no contraindications and things of that nature. What I will tell you is that for me, the revelation came when Walter Reed had its incident, and I became the chief of staff for the Army's Warrior Transition Command, starting it up. That was a time where I saw veterans who had served in Iraq and Afghanistan, and they were having challenges trying to prove that they received certain injuries in certain locations. And I'm like, that's a travesty. We have an obligation, in my mind, to make sure that people who are literally giving their bodies, their minds to our nation, that we indeed be there when they're most vulnerable. So having walked the ward at Walter Reed, having gone to different behavioral health locations, we are being impacted. We collectively. And so the whole question of never leave a fallen comrade is key and essential to me, but more importantly to their beneficiaries, the spouse who lost a husband or wife, or the mother who lost a son who is trying to get benefits based on, service-connected activities. We've all understood and have seen the effects of mental health and suicides, or drug-seeking behavior from folks who are dealing with pain management and things of that nature. So the new system allows us to see medical incidents inside of community hospitals. Okay, so I'm commanding the Fort Hood Hospital. A soldier could get medication at a battalion aid station. They can then go back to the ED, get medication. Then they can go off post and get medication. And nobody knew the wiser. And they take all the medication as prescribed by each bottle. And guess what? They go to sleep and never wake up. That's why I say this matters. This health system is the largest patient safety endeavor in the history of medicine. Period. Full stop.
Period, full stop, I would agree. What I would say is General Sargent used the term seamless. And he works for technology companies now. We invented that term seamless. It means no seams in your technology, right? But when we translate seamless into healthcare, we're talking about handoffs or gaps in your care. And it started on the civilian side, right? And for a civilian, I go to my primary care physician that's different than my hospital, right? And so I go from one to the other, and it might be in two different technology systems. That's a seam in my healthcare, or a potential gap in my care. And those gaps in care are the greatest risk to any particular patient. So what we ask of many of you in the military-connected families is to take on the risk of more seams, more gaps in potential gaps in your care, from your accession into the military, from every time you PCS, from every time there's not a certain specialty care in your community. We ask you to go to the community. From the time you transition from service into the VA system or whatever community health system you enter into, Those are seams or gaps potentially in your care that we ask for your service and ask you to take on that risk. We view it as our duty as the custodians of the technology to ensure that those seams don't become risks to your healthcare. And so that's why I do this, and that's why it's worth spending money on, is to protect those who do serve.
Yeah, and I think both of them summed it up well. And I think, we often think about this program just for the benefits of the electronic health record, in that you have your entire longitudinal patient record at the point of care with your doctor. So there's no loss of information or data, and they're not making decisions, clinical decisions, on any data that's missing. But there are secondary benefits that we often don't talk about. Many veterans are eligible for disability benefits and file claims for those benefits. Many of you are probably familiar with the claims processing issues and how long it takes to actually, get those benefits back that you have earned and deserve. Having an integrated electronic health record improves the processing of those claims because all of the data is in one source. So you don't have to go look for, hey, what care was I rendered here? What care was rendered there? What benefits do I get to pay for that care that I received? So it helps in many secondary ways that we also don't often talk about, that are also major issues within the department that exists today. So I'm excited not only for the primary function and benefits of the electronic health record, but also the secondary benefits for veterans.
Let's peel that onion a little bit. And I guess as a veteran, and I've heard this before, I've heard some of my fellow VSOs highlight, the idea of what does this look like for me, the veteran, at the veteran level? What can veterans expect to see in the coming years, and how does it change things for them?
Yeah, I think in multiple ways. One, I think first to start with, Pat talked about how if you've seen one VA, you've seen one VA. The most important thing is, regardless of what venue of care you go to, you can guarantee that you're going to get standardized care, because our system's based on standard care pathways. Those yield predictable outcomes. You get the best care because the system has been designed to provide optimal care. So wherever you go, you don't have to worry about where you go, because you're going to get a standardized set of care and a standard treatment plan no matter where you've seen. So you can guarantee that you'll get predictable outcomes and not worry, am I going to the best VA hospital that exists in this country? Do I need to go fly somewhere else to go get that? No, you don't have to worry about that anymore. The second area, I think, for veterans...
Let me slow you down there. Pick an example for me on that. Like, what would be an example of standardized care in that?
Yeah, so let's say you broken leg.
Yeah.
Depending on which facility you might go to, one physician might say, you need to go for surgery, or you might need to go an x-ray. Then we have to determine, are you going to get a surgery? Are you going to go through physical therapy? Are you going to, I'm going to have 8 visits, 8 weeks of physical therapy. I'm going to have 12 weeks of physical therapy. So those types of, decisions, while still enabled by the clinician, the system at least gives you the standardized protocol on which to follow. Now, the clinicians can still opt out of that, but it provides clinical decision support to the provider to say, here is the recommended national standard of how we would treat this type of issue for you as a veteran.
Yeah, so having commanded a hospital and have numerous hospital stays, having 7 surgeries, having survived a pulmonary embolism, I will tell you that what Avi was speaking about, because there's certain medical interactions that I've had in my past that if I wasn't able to verbalize what that was, and the system then put stuff, it could cause some catastrophic harm. But I do believe that from a tangible perspective, what we're trying to do is make sure that the physician again has the information in front of them in real time that affects their ability to make decisions about your care. But more importantly, I think over my time in the military, the 35 years that I served, there are different types of myths associated with healthcare. I'm in Hawaii in Tripler, and somebody comes back and say they call crippler. I'm like, what is that about? or a family member trying to have a baby in Killeen, Texas, folks say, well, we don't want you want to go to Darnell, you need to go downtown because that hospital is better downtown. Anybody have heard that kind of stuff? I see a lot of head nods. What I'm telling you, they are absolutely wrong for the reasons Avi just stated. But more importantly, the experience. So who's gone to the doctor's office and they hand you a clipboard and says, fill out all this medical information about your medications and allergies and all that stuff. And you got to sit there for 45 minutes trying to figure that stuff out. Well, in this new system, getting tangible, you can do it on a clipboard the night before. Okay, so when you show up at the clinic, you got all the information that you need. Now, fast forward to an 80-year-old veteran who has, Alzheimer's or what have you. Now, a caregiver can be able to go in and then champion their health care and make sure they get the right care, as an example.
Yeah, that sounds really amazing. And so we can program in Army pilot crashes his helicopter, and then the docs are just ready once. I like where this is going.
Not that simple. We don't crash, baby.
So Avi, you don't crash. Avi, that was step one, and I kind of interrupted you there. I don't know if you still have your train of thought.
Yeah, no, and I think Pat mentioned as a veteran, you are empowered with patient portal. So in your fingertips, you're able to do things like schedule appointments, cancel appointments, modify appointments. You're able to communicate directly with your provider should you have questions. Pat mentioned some of the clipboard functionality that allows you to fill forms the previous night, so you save time and you don't have to be in the office the next day, 45 minutes before your appointment, especially in an environment like COVID, right? So that's another benefit, I think, for the patients. Dan, you could probably add some more, but I think the biggest thing, and what we've talked about, is the longitudinal patient record, and the fact that you don't have to, as a patient, sit and try and recall every medication that you're on. Oftentimes when a doctor's prescribing a new medication, they need to know what you're currently on so that there's no drug-to-drug interactions. And you may have received that prescription at a different facility. And at the time of care, I think the average veteran is on close to 5 prescriptions. And so it sometimes, and they're always changing, right? So you're always required to remember what you're on if you're seen at a new facility. With this system, because it's one system for the enterprise for all of VA, the burden is no longer placed on you as a veteran to recall, what am I currently on? And it's at the clinician's fingertips. Moreover, when the clinician is prescribing that, our system provides a decision to support that says, hey, this individual, if they're going to provide a controlled substance, this individual may be prone to addiction. So when you are prescribing this controlled substance, know that's a behavior. It's a risk behavior. And so they can take those considerations into effect when making those types of prescribing decisions for veterans. So, the list goes on. I try to hit on ones that are particularly salient to patient safety because Pat did mention this is the largest patient safety endeavor ever taken on. And so receiving safe, quality care is what the veterans can expect in receiving improved quality and safety.
Well, I think the key word there is patient. I think most technology, you think it's for the person using it every day. Electronic health records, while we like to think ours is usable for the nurses, the doctors, et cetera, it's not for, you don't spend the money for the doctor themselves. You spend it for the healthcare of the patient and the experience of the patient. The VA right now is live with 5 facilities. And so when we think about the benefits to the patient, COVID's a great example because it's about the patient. There are nearly 10,000 examples today where a patient has said, I'm going to go to a VA facility because it's closest to my house and I'm going to get my first dose of my COVID vaccine there. And then I'm on vacation or for whatever reason I want to, I'm closer to a DOD pharmacy. So I'm going to go get my second dose of the COVID vaccine at the other facility, the other agency. And I don't have to tell anybody that. It is there for the physician to see. I walk in, I get my prescription done, or my COVID shot number 2 done, and it's there for me. So the ability for a patient, and we see a lot of times when service members, transition to veteran status, that mobility factor without having to take your records with you or tell the same history over and over and over again, that benefit to the patient is why we do this.
I think I've got a sense of why this is critically important to our community. I know with MHS Genesis, we've kind of got a head start on where we're at with VA. I don't know when did we start down the road of MH?
February 7th of 2017, Fairchild Air Force Base went live.
Okay. When were you at Madigan?
October 17.
That was one of the lead sites, right? What are some of the lessons we have as we roll this out? Because I think, most of the folks here in the crowd would know, I think in building something so innovative, trying to build something new, frankly, and then lay that over the largest consolidated healthcare system in the country is no easy feat that's going to be perfect. And I think there's a news article every time you guys are unperfect. So what have we learned about this approach?
Oh, great question. I think everybody in this room understands the term IOC, Initial Operating Capability. I'm a dust-off pilot. I transitioned from the Huey to the Black Hawk. Brand new aircraft coming up in the early 80s. And we had significant issues with the Black Hawk. Got a big stabilator on the back. And at some point, they had a malfunction with the actuator where the stabilator wouldn't rise as you started taking off, and the aircraft would crash. Did we stop the production of the aircraft? M1 tanks in 1992 or 92 when I was commanding a medical company in the 1st Cavalry Division. Same challenges, the OH-58 helicopter. What we have to understand is that while we're in a production environment, drawing a whiteboard and trying to figure out how to make the system work, it still has to be put into production. And then we have to be able to make adjustments. And in many ways, those things that we find that are error in the system, we then make sure that people, processes, and technology matches the requirement to mitigate them. Everybody knows about risk assessments. You've been in Iraq or Afghanistan, you do a risk assessment before you leave out of the gate. In an aircraft, you do the same thing. There's part of the aircraft survivability equipment that's not operational, but you understand there's another basic procedures that you can take to get from point A to point B. Likewise in medicine. So as you hear some of the issues related to safety, rest assured, in my opinion, not one hospital is putting you at risk for the utilization of this system. But as we move through the system, we had the same challenges that the VA is having right now in 2017. And folks, we stopped in 17 to 19 before we went back live. But as you know, the DoD now is halfway finished with their deployment. So this question becomes, what is the most logical route with regards to taxpayers' dollars, but also the ultimate piece of how to improve the healthcare system in a monumental fashion. This is a moonshot for our country. And so for me, I'm going to argue that I want to be on the right side of history. Okay, there's many things playing out in our country as we speak. And our actual healthcare system, or the system or the technology that's providing us care, is playing out as well. I heard a lot of political discussion come in earlier, and I would just tell you that this is not one time that somebody should be thinking as a Republican or a Democrat or whatever you are, because last time I checked, no bullet is going to stop and say, okay, you're a Democrat, so I'm going to pass by you, but I'm going to shoot the Republican. Okay? I come to learn pretty quickly, particularly in Desert Storm, the bullet that says to whom it may concern, that's the one you need to be worried about, not the one that's meant for you. Okay? So I would just tell you, push back on people who are parroting myths. For some reason, our country loves to be riled up by people who are spewing disinformation. And that's what's concerning me, because they have no interest in truly improving our system. And so if we let them, we being people who have served our country, and let me just tell you, these two gentlemen right here, are the biggest advocates out there for this particular program. And literally the survivability of them is standing on Avi's shoulder as we speak. No pressure, Avi. But my point is we need you too to get engaged. And I think if you're still on the Hill, you will have the opportunity to be able to speak to someone to change their minds. That's how I felt when I was a congressional fellow. The only person in Senator Durbin's office that had been in the military. And they listened pretty intently to kind of what I needed to say. But the point is that I did not go at it from, quote, he's a Democrat, so I'm going to tell him everything that the Democrat wanted to hear. That's being disingenuously, and I think you're dishonoring our uniforms and the sacred obligation to support and defend our nation if we abrogate our responsibilities, our oaths, and to that of trying to be, quote, partisan. Over.
Yeah, and generally, I worked under Secretary Shinseki doing congressional affairs when President Obama's first VA secretary. And at the time, we were undertaking a pretty big IT effort ourselves. And it was called VBMS, which is Veterans Benefits Management System. Some of you may or may not be familiar with it, but it was essentially taking paper claims records. Is anybody familiar with paper claims records? Am I aging myself a lot here? Well, veterans used to literally have stacks and stacks of papers, and they were their claim. And I mean, we had trunks at VA that were, sometimes literally 2 trunks full of paper, and that was one veteran's claim. And we literally had VA regional offices buckling, the floors buckling from paper because the weight of paper is not light. It's a lot of paper, or it's a lot of weight. And so we had to come up with an IT system to scan and digitize all this paper, get it into a processing system, and it was no easy feat. And it was fraught with issues. There were challenges. We had teams of IT people, and we had the users who we had to make sure the system worked for them. And so I sympathize with the scope of the project. I know how. In my mind, I can visualize how immense this actually is when you look at the number of patients we're talking about, the different practitioners, the different pharmaceuticals, and how that plugs into the pharmacy, the inputs, the outputs. I mean, it's kind of crazy.
Right, and let's talk about that for a minute. You mentioned MHS Genesis, which is now live with nearly 120,000 users using the system. The same system the VA is going to be using more frequently. 120,000 users are using that today. 3.2 million patients are being seen in MHS Genesis today. Wow. And I want to rewind back to around October 2017, because I think Pat Sargent has talked today a little bit about standardization and how standard process plus standard tooling equals standard outcomes. But there's also an element of leadership back there. Mm-hmm. And if we rewind ourselves back to October 2017 and early into 2018, I tell Avi this all the time, it's kind of like deja vu for me hearing those news stories of the number of tickets, or the tooling is causing issues. The tooling is impacting healthcare. And General Sargent at the time and his command team out at Madigan Army Medical Center crossed paths. I was out there with them, and he said, "No, everybody stop, right? It's people, process, and technology. The tooling is a component. Cerner team, or at the time, we're Oracle Cerner now, Cerner team, come out here to my facility. Mm-hmm. Let's get you with my people, and let's discuss process." And now, fast forward those 5 years, because this was site number 4. They have 5 sites live now. Fast forward 5 years, and we have those numbers of 3.2 million patients across 120,000 users. So if we can focus on getting those processes standardized, we can take care of standardizing the tool. And the VA will see 5 years from now, we'll be having the same conversation about the VA being where the DoD is today.
Yeah. I do want to ask you all one question, and that's, certainly, and similar to how I saw that IT program of taking paper and turning it into a processing system. But beyond that, it becomes, how do I build efficiencies? Right. And what I want to ask you guys is I envision my ideal VA as one that is super proactive and actually talks to me where I am, which is here too often, unfortunately. But it could be, boom, Justin, you've just turned 40. I'm almost 40. It's true. You need to shaking your head. We're all youngish. I'm just kidding. But Justin, you're almost 40. You need to consider an X-type exam. Can we schedule that for you? Justin, we see you got out of military service, in the last 6 months. Can we send you some data on post 9/11 GI Bill? I almost picture like us getting to a point where we have a really solid virtual assistant baked in to a lot of the program and delivery services we have that includes kind of medical care as well as proactive, ideally mental health care. I mean, my community, your community is facing a mental health care crisis right now. And I feel a lot of that is because we're getting way too far down the line and not doing more proactive things up front. Yeah. So that's a lot to throw at you all, but that is kind of a vision I see us kind of possibly getting to, within the realm of reality. What do you guys see?
Oh, I agree, but anytime I'm in a session like this, I have a lot of memories that come back. As a lieutenant in the 2nd Armored Division, we used to have the mimeograph machine with the drum, and it goes around to make copies. Anybody know that? We had typewriters at the time. We had the whiteout to do different things. Anybody know about disposition forms? Does anybody know about the routing, the envelopes?
Yes.
With the holes, you put your name and route it around, the couriers will come in and bring it around?
Yes.
And so we said that essentially, hey, look, technology will make us more efficient. How's that working out for many of us? Okay? Because it's all about people, processes, and technology, to your particular point. And I'm smiling when he says I'm almost 40, so that presumes that you are 39, and I'm sitting here as a 59-year-old and wishing I still had a 32-inch waist. But the point is that all of us, the health system, to your point, from a population health perspective, it's going to transition with you. And so there are BI and AI type of information that will force those particular appointments that you just talked about. I have a pituitary gland tumor as an example. And so I got to get an MRI periodically to be able to get that done. I got to go get through a special type of screening in my field of vision because this thing works on the optical nerve. Those things in your record are things that now are documented and gives you that particular fidelity to make sure that if this doctor forgets or you forget, it comes up and allow us to be able to do that. If you're diabetic, all those types of processes. So I think that reality is here. Now, can it be much more better in user interface when we have Oracle? And Oracle is an organization, clearly, that if you're using a banking machine, you use Oracle technology. So many of the things that you're describing that your generation are used to, these apps to be able to help you become more organized and efficient, they are world leaders at making it happen. Our boss today, Mike Cecilia, committed to the VA and to members of Congress that functionality that you just talked about will be coming in 6 to 9 months, easy. So be careful what you ask for. You're about ready to get it.
Love it.
Hello. So thank you for speaking to us. My name is Dosun Win. I served as medic in Afghanistan as well as some civilian clinical work. As a clinical researcher, I worked in hospitals and clinical laboratories as a phlebotomist and a lab technician. And throughout my experience, we used a handful of different like emergency medical records, Epic and MedTech and so on. And I think it's largely the consensus with a lot of medical experts that we'd like sort of like one system that's compatible across like all hospitals and industries. So say Cerner rolls out this new technology with the VA that makes, that sort of like is one system throughout the VA. But me as a patient, I decide that I want to go to Kaiser Permanente. And then, say Amazon just bought One Medical recently and I want to use Amazon Care. Is this new VA system going to be compatible with civilian systems?
Yeah, I'm happy to field that. In fact, today we fielded for VA back in August of 2020, something called the Joint Health Information Exchange. We are connected to, I think, over 3,000 community partners today. where there's an active exchange of medical information of patients, regardless of whatever system that private sector practitioner is using. So, the system is designed with APIs in mind so that there is that readily exchange of information. And I think most recently, a couple of years ago, there was actually a congressional, there was legislation passed called the Cures Act, where this was essentially mandatory for vendors like ourselves to have to share information in order to enable the types of things that you just mentioned. So seamless care between not only inter-VA, but then intra between DoD, Coast Guard, and VA, and then even with community. So we're talking about a nationally connected health network when we're done with this program.
I was only going to add that, Cures Act did come around, and I'm not going to disparage any of our competitors that you may or may not have mentioned. But I will say that from a policy perspective, Cerner was at the front lines of arguing for that open interoperability. Oracle Cerner believes the same thing. Larry Ellison presented to industry with the same vision of improving the public health infrastructure where all of those data points enable the data for research to be available, to enable the patient to have fluidity in how they want to navigate their lives. We've been at the forefront of that from a policy perspective for years now and helped to advocate for the Cures Act. And that's the vision that we see as well and advocate for.
Hello, Yusuf Enriquez, U.S. Army medic, HillVets lead, Cohort 6. So interoperability is an area that I've been concerned as a general. You mentioned I'm a veteran, and I know genomics is now a huge part of how we're going to be looking at precision medicine. I do understand that Cerner has been at the forefront from the electronic health record standpoint, but as you know, genomics takes on a significant amount of data storage, and wanted to kind of hear where Cerner is going in the future as far as using that information, which I think is going to be key to look at health outcomes for individual veterans that are within the system over their career of their lifetime, to look at epigenetic changes and some of the precision oncology and precision medicine that could be used to have better outcome and insights before these vets get down to stage 3, stage 4. So just wanted to hear kind of what you guys' roadmap is for including genomics as part of that universal kind of health system that's going to help look and treat veterans.
So I'll start with kind of what I was involved with before I retired, and let then Daniel and folks speak about the capacity of kind of how we're going to manage that within the context of the infrastructure. But to your point, we know that you can get very precise by mapping genomic linkages, although that presents some ethical challenges as well, particularly when we likely start then disqualifying people from joining the Army because we believe that down the line they could get a certain amount of, will have, cancer, prone to cancer. Should we do that? And so that precision that you talk about, it truly, we're capitalizing on, if a soldier has cancer in the United States right now, they're able to go to, just say Bethesda as an example, huge oncology type of ward. VA has some of the world-class oncology treatment plans going on, NIH trials and things of that nature. So I do know that today we are capitalizing on that, particularly for conditions that that requires to titrate medication more specifically designed for that particular cancer. So rest assured we're doing that. But on the context of the question of the capacity to be able to scale within information, I know that Oracle brings that particular capability to us, and things are going to the cloud to kind of enable that much better, because again, I think all the hardware stuff that I came in the Army with, that stuff is old now, to your point. And we're having outages that's related to us doing the traditional stacks and hardware, and then manually going in trying to put the patches into the system versus all that being managed by technology. And that's where this system is going to go, to make sure that the downtime that's associated with interoperability or readiness or stability and reliability, that stuff should go away. I'll defer to Avi and Daniel for the rest.
Yeah, what I would add is, I'm probably going to get your name because we're actually writing a white paper on our perspective of precision medicine for the military health system right now. So I'll probably get your name and ask you to red team it for us. But I will say that as an organization, we have what we call the Learning Health Network. And that takes the continuum across our 18,000 clients that we have worldwide, de-identifies the data, but allows research organizations to tap into it and follow the trends of evidence-based medicine, leveraging it for things like clinical trials. So we have a lot of thoughts, and frankly, the thoughts turn to action with the power that Oracle brings to get to hyperscale when you talk about data centers. And the more data you have, the more you can normalize it, the more you can aggregate it, the more you can use it, the more effective you can be in transforming how we deliver medicine generally.
One thing I also want to say, because you make a good point, I think it's not lost on all of us that COVID truly had a devastating impact on this country. 1 million plus people died unnecessarily, okay? I mean, people took their political will and positions to their deaths. That's speaking very candidly about the technology that we had available to save folks' lives. But we politicized a healthcare system that could have preserved those particular lives. Shame on us. Okay? Shame on us. Likewise, from a diversity and inclusion standpoint, the things that you just talked about, having that capacity, everybody gets treated with the same type of medication. It's not for the wealthy or the poor, okay? You go to the vulnerable communities is what we kind of got to term with. I was in that vulnerable community. I'm an American in a vulnerable community. So we dehumanize certain aspects of our medical system. The things that he just talked about are going to allow us to take that off the table. And for a person who is a minority in this country, I want that to be done, because I know about some of the challenges we had with infecting people with syphilis and then trying to figure out how it's going to impact them and not tell them about it. Okay? Taking a person's DNA, solving challenges and not telling them about it. That's what we did in this country. Okay? So what I'm telling you is that people need to wake up if we're trying to have a humane healthcare system that's eligible for everybody in the room. And you can go take your partisan belief left or right. But the fact is, we were providing more evidence-based medical care to Iraqis. And I came to Iraq at 4,000 detainees. When I left, it was 28,000. And we had electronic medical record that could tell if they had diabetes, they had blood pressure, and all of that stuff. Well, why can't we do that in the Delta of Mississippi? Why can't we do that in the hills of West Virginia? And my point is that you and I served our country. Your record is going to give us all of that. So now you tell me, which medical system is best, the civilian or the military? I'm going to say that the military system is probably better for you, and then transition to the VA health system.
Yeah, I'd add one other item if I could. One of the utilities Cerner does offer is something called social determinants of health. So you mentioned, how do you get to more predictable health outcomes? That's not just being given treatment based on a particular condition you may have in the moment. What we do is we take in various inputs, be it on your ethnicity, be it on your diet, be it on your geography, and we can start to understand through data what conditions you may eventually show up, what might eventually show up in your future lifetime. And so that type of data and that type of insight, and you talked about what can we envision in the future. Mm-hmm. These things are happening now. We're able to use more than just your health data to determine what health challenges you might experience later in life, just based on things like geography, ethnicity, diet, culture, because those are all contributing factors to and predisposals to what health conditions might show up later in life.
I want to put the other side of that equation. I appreciate the social determinants of health, but there's something called health inequities as well. So if I can't go to a Whole Foods to buy whole food organic medicine or equipment in my neighborhood, I'm going to get fat, period. If I can't go and if I'm not smart enough because I don't have all the education, I'm not going to be able to go to the doctor and do what? As Daniel said, to be able to provide them enough information on your history to be able to take care of them appropriately. So we also know that with all those health inequities along with the social determinants of health, do you have to worry about that as a military member and a veteran? No. How many of you paid your co-pays for medication? I'm standing in line at a CVS, and a lady goes up to the counter, older lady, because it was somebody's grandmother, and the guy told her your medication today is going to be $840 something bucks.
I think mine was like $8 once.
And that lady said, "How much is a week's worth?" Or a person says, doc says, we said earlier about evidence-based care said you're supposed to have 21 weeks of physical therapy. But insurance says you can't get it but 8. But guess what? You're going to get exactly the treatment that the physician says because of your status. And we're paying $532 a year for health care for a family. I know I'm going to make these guys mad right here because I'm sure they're paying way more than that. I'm just saying the value of your health benefit.
Good evening, John Myers. Go by name is Puddles, active duty Air Force, and I'm a lead cohort 7 member. So I'm going to preface my comments with, as an active duty Air Force member, I'm stoked about this. It's great. But I was a prior Air Force recruiter, and we look all through the news about the problems that DoD recruitment's facing. But what you don't see is the worst kept secret that any recruiter will tell you, that just about every applicant that walked through my door is, air quote, disqualified to join the military. Prior to MHS Genesis, for lack of a better word, you could coach these members to get through the MEPS process. They can no longer be coached through it. Everyone's pointing fingers at why recruitment is suffering, but I can tell you it's because it's what I believe is an unintentional consequence of a good system. So my question is, was this at all considered when you guys were rolling this out? Is it currently being talked about? And is there any way we can maybe delay applicants' entrance until they already are assessed? Over.
Oh, I like the question, and I read the article that spoke about the impact on recruiting. And so I think it is an injustice to a recruit to be brought into the military when we know they have a condition that's likely going to impact their readiness to be a part of a tank crew, an air crew, or to be a part of any unit to meet the medical standards associated with their military MOS. Secondly, I think when you start looking at it, at the levels that you guys are on Capitol Hill, what's the number one cost in the military? Personnel costs. So now we put this person through basic, they go through the training, they go to AIT, they go to their unit, now we can spend all kind of money on them. They've been in the Army more than 6 months, say Army military more than 6 months. And then all of a sudden we find this condition, and now we got to send them home. Think about the amount of money that has been invested in an individual, and then the impact on the readiness. During Desert Storm, while I was commander of our hospital, there was 2 divisions worth of soldiers medically not ready to go to combat. There were people who, based on the medical system at the time, because they weren't going to the clinic or they await to the, what do you call those things, pocket profiles, hold a profile to now you get your brigade getting ready to go. Oops, I'm sorry, I'm a diabetic. Because we didn't have the line of sight to understand that. So the first category in some cases had 3 deployments to Iraq and an individual never deployed. That's not fair. And then secondly, once the person is in the Army, past 180 days, guess what? Now they're eligible for benefits. And now we're talking about your tax dollars and other folks paying that individual for the rest of their lives. So I'm not trying to say that, it's a bad thing or not, but I would just tell you that the last time that most units, particularly when you do a USR at the end of the month, how many pilots you had to go fly the F-16? It comes down to this question of can you do the mission? After Walter Reed, we, the secretary and other folks, made changes to our medical status, disability status. Greg Gaxon, double amputee, he was on active duty, went to brigade command. But we know he couldn't have deployed. But at some point, our Army grew with non-deployables. And the last time I checked, the Army's mission is to defend and support our nation. And most people you can't do that. So there is a balance. I'll just put it, there's a balance. But I do think that, ultimately, we got to make sure that the person can perform the requirements associated with their military occupational skill. But if they're on active duty, to your point, if they then come down with a condition, we need to make sure that it's properly documented and that person get compensated for the things that they couldn't do. I don't know if that answers your question or not.
And what I would say, just to add on to answer, yes, the conversation is happening. And as you're aware, MHS Genesis is deployed to MEPS facilities, and it has been mentioned as a contributing factor in recruitment status. We view the fact that we're having the conversation here as a good thing. We're not saying, it's not on us to say, at least not on Avi or me. I'll defer to General Sargent as to who should or shouldn't be enlisted. But from us, it shouldn't be our decision to, what those entry criteria are or aren't from a healthcare perspective. What are those disqualifiers? But the fact we're having the conversation about it, and the fact that you're able to ask that question, means that conversation's happening in the open air, and we do view that as a good thing.
Let me just make sure I'm clear. This, my opinions are the opinions of Patrick D. Sargent. It's Sargent, and not that associated with Oracle, Cerner, or the United States Army. I am retired. Okay.
Well, gentlemen, truly appreciate you all taking the time to be with us. Truly appreciate everything you've done for HillVets and really being one of our original supporters to build HillVets House on Capitol Hill. And so, personally, I'm very excited about the project. I'm excited about what I think the value will be for veterans, not just of my generation, but I think for many generations to come. And I think it's really one building block in what is going to turn into, things that I can't even fathom at this juncture. And I also think, and people I don't think fully realize this, but it is on the cutting edge of healthcare delivery, right? I mean, I don't think a more ambitious, healthcare delivery IT, overhaul / project going on in the nation right now. So I'm excited that that's at VA and that VA does get to be the lead on that.
I just want to say one thing as we close. I want you guys to really think about the value of the program that you're experiencing right now. As a major on Capitol Hill, working for Center for those 2 years, I really didn't understand it as it relates to how it would shape my ability to think about, national geopolitical type situation in our nation, to understand, how do you advocate for folks, particularly as it relates to, the appropriations process in the legislative process, to advocate for the Army when I was in legislative liaison. It's a powerful position that you have. To me, it was the transformative aspect of my career at that particular point, understanding how to connect those dots and seeing the patterns that some people really can't see because they haven't been exposed to it. I would tell you that this organization, I respect, I admire. I know you guys said cohort. I still have contact with my congressional fellowship class. I would ask that you guys do the same, because 10, 15 years, there will be, I heard you guys talk about members of Congress, and there will be generals out here for the active duty folks, or there will be a senator, there will be a congressman, a governor, whomever. Keep that connection. So I'm hopeful you guys are generating rosters, because you will never know when one of your colleagues who is sitting in that seat today, they're going to need your support to really make monumental impacts to our nation and to their respective communities. So again, I'd like to thank the Secretary for being here. He's the chairman of our board at Oracle, and it's for a very purposeful reason. You heard him speak. Very dynamic individual who has a lot of care, concern, but more importantly, the passion to be able to drive some of the things that we need to drive. As you guys know, if you want a friend on Capitol Hill, you better go get a dog, okay?
Or join HillVets.
You go get a dog, okay? But HillVets is that venue, so